A very happy new year and a very warm welcome to everyone. My name is Kunal Kishore and I'm very pleased to welcome you to the second regional ASEAN workshop titled Future of Harm Reduction in ASEAN, Ending Injection Related HIV Transmission on behalf of Alliance India from New Delhi and our partner SCDI from Hanoi. At the outset, please accept our deepest gratitude and appreciations for making it to this event, even on the last day of this very difficult year, and when you may wish to be with your near and dear ones. Looking forward to a very happy new year, and of course, without COVID. Um, I have a number of guests here who I need to acknowledge. And the list may be very long, so I'm just taking few names, and I would please excuse me if I miss some of your names. But to begin with, I just wanted to welcome from the ASEAN People's Forum, also our partner for the event, Ms. Lee Thi Tan Ha. She's member of the drafting committee of the ASEAN's People Forum, and the committee organized consultations and draft statements by ASEAN People's Forum. We also have Professor Des Jarlais. He is a well-known personality in the global HIV community as a leading researcher when it comes to HIV transmission amongst people who inject drugs. He was amongst the first researchers looking at the issue in New York City in the 1980s, and since then has been the principal investigator for many researchers on the topic in different countries. He advises governments and UN agencies on strategies to address HIV epidemic amongst PWIDs. We are very fortunate to have Associate Professor Duong Thi Huang. Until very recently, she was the Dean of the Public Health Facility at Phong Medical and Pharmacology University. HIV among PWID is one of the major research interests for her, and she is the co-principal investigator for DRIVE research project that she is going to present later today. Welcome also Dr. Nguyen Thi Minh Tam, head of the Prevention Unit, Vietnam Administration of AIDS Control. She's a medical doctor with PhD degree in public health. Her unit oversees the implementation of harm reduction, and very fortunate to have her with us. They also advise the AIDS administration and Ministry of Health. And it's a very important time because Vietnam is leading, championing the HIV prevention agenda in Asia. I will hear from her how they are doing it. We also have Dr. Khuat Thi Khai On, our favorite Oanh. And Oanh is the executive director. The reason why this meeting is happening even on the last day of the year, she was amongst the people who designed the first Global Fund supported project managed by civil society in Vietnam, which started to operate in 2011. He is also a co-principal investigator of the DRIVE study, which we'll hear later. We have Ms. Nicole Delaney. She is the Senior Fund Portfolio Manager for South and East Asia team at Global Fund. In fact, it's with her leadership, support, and strategic guidance that this grant has come a long way in Asia. It was initially a 3-year grant, now 4 years, and we've achieved a lot with her support. She's also the lead for Nepal, and it was through her efforts and support to the country partners that Nepal has made a successful request for another Global Fund round on harm reduction. We also have colleagues from Nepal here. We have Dr. Salil Panakadan, who at UNAIDS Asia office leads the prevention efforts, which includes working with key populations and on harm reduction. In fact, we are very fortunate that under his leadership, harm reduction has made noteworthy progress, especially if you recall the late discussions on the ATS use and chemsex. It was under his leadership that a lot of progress has been made. There are a lot of discussions going on within the UN community. We welcome you, sir. And if I may move forward with the formal agenda, before I invite Dr. Salil to present briefly on behalf of UNAIDS, if I can request all of you to please mute your mics and we'll try as much as possible to finish in time or maybe a little early so that you can go home. And we'll take questions in the end. So over to Dr. Salil Panakadan from UNAIDS for his opening remarks. Sir, over to you.
Kunan and Dr. Salin, may I just interrupt for 30 seconds? We just to remind our Vietnamese participant that we have a translation. Các bạn dùng tiếng Việt thì có thể chọn cái chức năng dịch ở cuối màn hình ạ. Ở dưới đáy của màn hình thì có cái hình quả cầu. Có chữ interpretation, thế nếu mà mình bấm vào đấy thì mình có thể chọn kênh tiếng Anh hoặc tiếng Việt. Khi mà mình chọn tiếng Việt thì mình sẽ nghe được cái từ dịch tiếng Việt, mọi người là dịch song song luôn ạ. Và xin cảm ơn mọi người. Okay, over to you, Dr. Salil.
Thank you, Kunal. Duong, sorry, I couldn't pronounce your name. So yeah, thanks both to Alliance India and SCDI for organizing this. Last day of the year, and I have never ever attended anything like this on the last day of the year. It is great. Happy New Year to all of you, all of us who are, I actually just left the scene outside and came into my room to make this short introduction to this meeting. Thank you once again for having me here. Now, I see that the topic of the discussion is future of harm reduction. And from our point of view, 2020 has been a very difficult year. And looking back, it looks like it's kind of mixed results. While we have had program interruptions throughout the region, not just for drug users, but all key populations, there has been some good news also. Let me start with the uptake of take-home OST in this region. I think it's a side effect of the harm of the lockdowns due to COVID epidemic that take-home dose introduction has speeded up. Murdo is here. He knows about the situation in Myanmar. Probably the first country anywhere where they're giving take-home dosages for 2 weeks and more, which is something which we see only in Myanmar. We also see take-home being introduced in Vietnam this year. India, the pending reforms kicked into motion. So overall, we see the take-home dosages as far as OST is concerned becoming popular with governments, and the opposition slowly, I wouldn't say it's gone completely, but slowly reducing. Another piece of good news is from Pakistan. For the first time, they have accepted OST as something to be implemented. It is yet to actually start. We understand that finally the Narcotics Control Board has also agreed to that. So that will be a major progress for this region, because we have been having a lot of problems in spite of harm reduction, OST, being part of Global Fund programs, but not being implemented. So these are some pieces of good news that I can share as far as we see it. But overall, situation continues to be not so good. Compulsory drug detention centers are still operating in many East Asian countries. We have come out with joint statements from the UN system and other development partners to discourage the practice of having the CCDUs in the region. So that's about, I would just summarize what we think has happened in terms of harm reduction for injecting drug users. Now, one new factor that we are increasingly seeing, not so new, but for the people in the field, is this increased use of stimulant drugs, the ATS. And there are reports that up to 30% of ATS users also inject. So harm reduction for ATS users, both injecting or non-injecting, are something that is coming up as a priority, and we have tried our best to, along with UNODC, to convene partners in the region. Murdo and other colleagues, Kunal, were there in the meeting that we had in 2019, end of 2019. This year, of course, we could not have any physical meeting, but we did try to manage and get something on chemsex. So increasingly, ATS use is an additional area that we want to work very hard on, while the opioid harm reduction still remains a challenge. Finally, I would like to place on record the extremely good partnership that we have had in terms of advocating for harm reduction, in terms of rolling out new initiatives for harm reduction in the region, both for stimulant and drug users and for opioid harm reduction. And I would want to place on record, on behalf of UNAIDS, the excellent work that this particular Asia Harm Reduction grant of the regional grant of Global Fund has been doing, and especially the efforts of Kunal, the team in Alliance, and Nicole from Global Fund. We have had some starting problems 2-3 years ago, but it's good to see things have caught on since then, and we are in a good situation to carry forward the gains from this harm reduction initiative at the regional level to something which should continue. And we look forward as UNAIDS and UN system in the region to support the communities and all players in this region to continue the good work and expand services to those who need them. Thank you very much. Once again, a very happy new year.
Thank you so much, sir. Very encouraged, and thank you for always being with us. I think almost through the 3 years journey that you are alluding to, you've been with us and working hand in hand. It's been tremendously helpful also in taking the UN agencies throughout the region together. And we look forward to your continued support to carry the good work that's been done. I would now like to quickly invite Ms. Nicole Delaney from Global Fund. Nicole, as I have introduced earlier, is the force behind all the good work that's being done, all her guidance and her strategic advice, even training, doing some hands-on training for us and the entire partnership. So Nicole, over to you. Yeah.
Good morning, good afternoon, everybody. It's an absolute pleasure to be with you today on New Year's Eve. As Salil has pointed out, what a way to finish 2020 with something so positive and exciting. And also the last day of our grant before we go into grant closure, which for me, I have to say is actually quite sad, because I've felt, I've had a lot of professional, rewarding experience of being able to work with you. Until this year, we were meeting 3 to 4 times a year, normally in Bangkok. I think we managed once in Cambodia, to work together in defining for each of the countries that you work in, what are those low-hanging fruits and long-term objectives that we really need to keep tapping away at, so that we can make sure that we've got services for drug users in each of our countries, and that we're working towards their long-term sustainability. And Kunal, thank you for your kind words, but really all the hard work was done at the country level. And I mean, I do recognise the efforts that you've undertaken, because I think each of the partners comes from quite a diverse background of where you're placed working directly with drug users. Some of you were service providers already doing harm reduction services. Some of you were more in the on the legal side, providing legal services to drug users, and some of you were working already on policy reform at the government level. I think that we did our analysis 3 years ago and saw how low some of the harm reduction services were in some of our countries. And so, Salil, it's encouraging to hear you say, despite the challenges of this year, the progress that we've reached in each of these countries. And so I think it's really fitting today to finish the financing from the Global Fund side with a status update on where we are, and especially then for our ASEAN leaders and policymakers that are with us to hear this, so that we understand where we are in the fight and where we still need to go. And perhaps just a snapshot from my side, again, the framing that I've been using over these last years. What we're trying to do is reach 90-90-90 targets, and I know these are going to change. UNAIDS is leading us there. At some point, we'll be aiming for 95-95-95 if we're not yet. And at some point, this needs to move across into just, you know, absolute coverage to the extent that we're able to. Services for drug users. And here I'm talking about the HIV targets of prevention, testing, treatment, and keeping on treatment. And in order to be able to do this, we need to make sure, first of all, that we have our data up to date and accurate, that clearly represents the drug users, the number of drug users that we're trying to reach. We need to define in law the services that they need to receive based on demand, not based on how much financing is available. It's not going to help if we've got 2 needles per month or per half year for drug users if they need, who knows, 7 to 15 a week. That needs to be worked out together with the drug users. And of course, we have our minimum standard settings that should provide a basis to start with. We need to have definition for services for differentiated groups. So this is, for example, chemsex, our female drug users, and places where they can go to, the differentiated groups, to access services if they're not coming through into the health system. So the third element that we need to work on is capacity to provide services. If it's not the health system, then it needs to be through the community-based organisations, through communities, through NGOs, those that are closest to the people that we're trying to reach, and that are, have the people and the staff in place, maybe even the modality, going out to the streets rather than expecting people to come into drop-in centres. That part needs to be worked out. Then we've got the whole area on addressing the barriers to accessing services, which might simply be resolved through having additional drop-in centres, but we're talking here also about stigma, discrimination, policy and legal changes. And then ultimately what we're trying to do for their long-term sustainability of the services is to make sure that there is long-term financing. As long as we have external donors coming in to provide money, which we are in quite a few countries now, and I hope increasingly in our countries that you're using the Global Fund funding request country dialogue processes to be putting these activities forward as a priority intervention that should be financed from the Global Fund if they're not yet financed nationally. But the aim long term is to get all of these important activities also funded through national financing. And this is one of the arms that we need to continue working on over the coming years. I think we've seen some successes. We've seen different countries going to a regional and a community-based level to start tapping into local public financing that is available. But this is, I think, the area that we need to continue really working on over the coming years. Yes, so those are those 5 prongs, the 5 elements, the 5 basic pillars that we need to think about. So wherever we come from, be it policy, be it service delivery, be it data, number crunches, we need to work in partnership. We can't do this in an isolated manner. We need to work with the advocates that are closely linked to our public policy makers, the government, so that we can work as efficiently and as effectively as we can over the coming years. I hope some of this work will be picked up in terms of financing through a regional grant that the Global Fund will be starting, I think, in 12 months' time. We're a little bit unlucky. I mean, we were very lucky that we got a 4th year out of this grant, but we're a little bit unlucky that we couldn't get a 5th year to tie us over to the next grant. I do hope that you'll continue your advocacy work, though, because ultimately it's your voices that are the most powerful. I can just try and help channel them to where decision makers might be for financing. Salil is obviously a critical ally and partner here, and I just keep encouraging you and asking you to keep your voices up and as loud as you can be without jeopardizing the critical work that you're doing in your countries, so that we can continue advocating for those that are unable to do it for themselves. So look forward to this meeting. And again, as Salil also said, wishing everybody a wonderful new year, and let 2021 have all those fruits that we had trouble trying to harvest this year. So in abundance, at least doubly. Thank you. Thank you, Kunal, for inviting me to talk this morning.
Thank you, Nicole, for making it. Actually, you know, when we were planning this event with Juan, it was largely because she provided the leadership, but also because we thought we could, you know, convince you all to be with us on this very late fag end of this project. And thank you also for being very candid about, you know, where we need to go from here, how things are looking up inside Global Fund. But we will still look up to you to steer us forward in terms of taking the good work of this project, because there are still some unfinished tasks, and I think we are well set to just bring this 4 years of momentum together will be a nightmare, I would say, to, you know, so we look forward to your guidance in taking all the good work that our partners have done forward. And thank you so much for making it. Moving on, I would like to invite our third very important partner, the ASEAN People's Forum. And if you could kindly enlighten us, Ms. Lee Thi Tan Ha. Ma'am, if you could kindly share some remarks from your side from the ASEAN People's Forum. I think you are muted, ma'am. Trang, if you can.
Good afternoon, everyone. I am very pleased to join with you today, and thank you, Kunan, to invite me to discuss with you. As Kunan earlier mentioned, I am a member of drafting committee of ASEAN People Forum. Please accept me a minute to briefly introduce the ASEAN People Forum. ASEAN People Forum is led and organized by CSO in 10 Asian countries. And every year we meet one to discuss and submit to ASEAN government the common issue in region. We want to bring the voice from bottom to government and agency. Vietnam is a chair of ASEAN for 2020. So APF this year took place in Hanoi from 5th to 7th of November. The APF, also known as ASEAN Civil Society Conference, and it held independently by the ASEAN chair country. Drug use continue to be a big concern for people of ASEAN, and HIV infection continue to negatively affect the life of many people who inject drugs in ASEAN. It is important that we work together and share experience to jointly and collectively combat this virus. We are very pleased to see this workshop happen. This is in the spirit of forum being inclusive, cohesive, and responsive to the people of Southeast Asia. As all you know, the spreading of COVID-19 pandemic prevents us from meeting each other in person, but it can never prevent us from strengthening our solidarity and cooperation. The online meeting today is also another testament of ASEAN people are adapting the new normal life. I believe that we will have a fruitful online meeting. We thank HRAsia and SCDI for organizing this workshop, and thank Global Fund and UNAIDS for support. I also to take this opportunity to wish you all a very safe, healthy, and very happy New Year. thank you all for listening.
Thank you so much.
Yeah.
Thank you so much, ma'am. We are very encouraged that you could join us. We need your kind of leadership to take this important work forward. And since you're also representing the ASEAN People's Forum, I thought it's the right time to also acknowledge the presence of a number of community and civil society colleagues who've joined us. I can see a number of friends who joined us in the last 5 minutes. So welcome to all of them. I have a lot of names I have to take, but just very happy to see so many community friends have joined us also. So Juan, I think we are doing very good with time. And if you agree, we will just move to the next session. And we would like to invite Professor Des Jarlais from the New York University. It's a very, very important presentation. And basically, we are going to hear from Professor Don about ending injecting-related HIV transmission, and how can we get there, and how do we know if we can get there at all. So over to you, Professor.
Okay, thank you. And I'd like to thank the organizers for inviting me, and also wish everyone a Happy New Year. I'll be presenting an overview of ending HIV epidemics among people who use drugs. This is based primarily in studies of ending the HIV epidemic in New York City and in Haiphong. I'd like to acknowledge the DRIVE study team, all 74,000 of us, because it's a very big but cohesive working group that I think has done excellent work. Next slide, please. Okay, yeah. The purpose of the DRIVE studies was to determine if combined prevention and care can end the HIV epidemic among people who inject drugs in Haiphong. Next slide, please. The study involved a lot of research with people who inject drugs. There were 4 annual respondent-driven sampling surveys that measured risk behavior, that had HIV, HCV, and service utilization data. We studied HIV incidence among people who participated in more than one of these 4 surveys. Each of the 4 surveys was about 1,500 participants. We had cohorts of people who were HIV negative to examine service utilization, particularly methadone treatment, and also for HIV incidence. We also had cohorts of HIV positive people. All HIV positives from the RDS surveys were entered into a cohort, and we examined methadone maintenance and ART and viral suppression among the HIV positives. The original study was what we call the risk factors study based in New York City. And the purpose of the risk factors study has basically been to compile a complete history of the HIV epidemic among people who inject drugs in New York City from 1978 to 2020. The study actually started in 1983, but we had blood samples back from 78, and we're continuing the study in 2020. So we have a very, very long period of research for New York City. Next slide. I'd like to acknowledge colleagues who've worked with me in New York on the risk factors study. Next slide, please. One key question that has been addressed is it possible to eliminate syringe sharing among people who inject drugs? Obviously, if you could eliminate syringe sharing, you would be able to completely stop injecting related HIV transmission. Next slide, please. Unfortunately, the answer is no. It is not possible to eliminate syringe sharing in any large, diverse population of people who inject drugs. You have syringe sharing occurring because occasionally people will lack sterile syringes, even in sites where syringes are readily available. There will be an occasional instance where you have more people who want to inject, but you do not have enough sterile syringes. And then a more important factor is interpersonal dynamics. People who have close social relationships, sexual partners, close friends, develop trust in their partners, and that leads to sharing syringes, a sense of we have a common fate that could include a transmission of bloodborne viruses. If you're engaging in unsafe sex with a sexual partner, it's difficult to always avoid syringe sharing. Next slide, please. Given that it's not possible to completely eliminate syringe sharing, how do we go about studying the possible end of an HIV epidemic? In both New York and Haiphong, we used multiple measures for studying HIV incidence. We tried to have as many ways of measuring incidence as possible in order to look for consistency in achieving very, very low incidence. Next slide, please. Okay, there are particular concerns for reducing HIV among people who inject drugs in low middle income countries that I want to mention. Police activities often interfere with the use of services. There's often a lack of financial resources. There's a lack of trained personnel. There's the intense stigmatization of drug use and of HIV infection. And many of these countries have counterproductive policies, putting people who use drugs in detention centers, quotas for arresting people who use drugs, and a denial of drug use and HIV as public health problems. So particularly the work in Haiphong had to deal with these issues. Next slide, please. In New York City, we used a cohort study. We also did mathematical analysis of the slope of HIV prevalence to see that it did not increase much as people increased their duration of drug use. We also had the New York City Department of Health HIV surveillance data, which is excellent. All laboratories in the city that do HIV testing report their results to the City Department of Health. We also use the New York State Department of Health surveillance for HIV, which includes specific modeling to address potential incompleteness of HIV surveillance and also potential late reporting of infections that are no longer within the range of being incident infections. Okay, next slide. Back one. Yeah, in New York City, all of these methods showed an HIV incidence of less than 0.4 per 100 person years of risk for 2012 to 2018. We're working on the 2019 and 2020 data now, but for a period of 7 years, we had extremely low HIV incidence. It did not vary from year to year. It was, for all of those years, it was less than 0.4 per 100 person years at risk. Next slide. For Haiphong, as I mentioned, we had cohort studies of HIV people who were HIV negative, where we interviewed them and got serum samples every 6 months so we could pick up new HIV infections. We used HIV recency testing, which allows you to determine if an infection has occurred in the previous 6 months prior to the serum sample being collected. And also I mentioned we had large respondent-driven sampling surveys. In many of those surveys, we would get people participating more than once. So if they were HIV negative in the first survey they participated in, we could see if they became infected by the time of the next survey. Next slide, please. These different methods, when combined, showed an incidence of less than 0.1 per 100 person years at risk for 2014 when we started with the first drive-in study through 2019 when we finished our fourth large RDS survey. So both in New York and Haiphong, we did find very, very low incidence. We defined ending an HIV epidemic among people who inject drugs as HIV incidence of less than 0.5 per 100 person years at risk and maintained over time. In New York, it was 7 years. In Haiphong, it was 6 years. So not only were we able to see very, very low HIV incidence, it was maintained over time. It did not go up or down over these long periods of time. Next slide, please. Okay, we've been doing agent-based modeling of large epidemics of HIV among people who inject drugs. And this has identified two particular key variables for achieving low HIV incidence. The first is that you want to have a very, very low percentage of people in the PWID population who are likely to transmit HIV. These are people who inject drugs and are HIV positive, not on ART, and engaging in distributive sharing or passing on their used needles to other people who inject drugs. In both New York and Haiphong, these people who are particularly likely to transmit HIV are less than 0.5% of the PWID population. The second key variable is trying to have a minimum of people who inject who are likely to become infected with HIV. That is, they're HIV seronegative, they're engaging in syringe sharing in relatively large groups of 6 or more people who inject. Again, in both Haiphong and New York, the people who were likely to become infected with HIV was 0.5, half of a percent of the population. Next slide, please. One thing we found both in the empirical data and in the modeling, that syringe sharing in small, stable groups really did not affect the HIV incidence very much. It did generate some new HIV infections, but it did not set off outbreaks of HIV. These small, stable groups were people like sexual partners, close friends, relatives. These groups were likely to be seroconcordant. In both cities, most of these people sharing in small syringe groups were HIV seronegative, and so they did not transmit HIV. You did see occasional change in these groups. For example, a sexual partnership may break up and people start up with new sexual partners. Those changes in the groups can generate HIV incidence, transmission of HIV, but they don't generate long chains of HIV transmission. So again, with this type of syringe sharing that is extremely difficult to try to eliminate, if only a small percentage of people are sharing outside of these small groups, you will not get outbreaks of HIV, of long change of HIV transmission. Next slide, please. However, with all of this very good news from the two cities, it's also important to point out that we have had recent outbreaks of HIV among people who inject drugs, in particularly Western Europe, Israel, Canada, and in multiple sites in the US. Some of these have been rather large outbreaks with hundreds to thousands of PWID getting infected. The analysis we did of these recent outbreaks pointed to certain common factors. There were community economic problems in all of these areas. There was either inadequate or disrupted HIV prevention programs. Often there were new drugs injected, particularly cocaine or novel psychoactive substances. These drugs typically had very, very high frequencies of injecting, so that people using them did not have enough sterile syringes for the higher rates of injecting. And also we saw that homeless people who inject were a highly vulnerable subgroup, that homeless PWID were particularly likely to become infected in these outbreaks. Next slide, please. And I should mention that the COVID-19 pandemic is creating the conditions that led to outbreaks among people who inject drugs. The homelessness, the community economic problems, the disruption in services, and changes in drugs injected have all been observed as part of the COVID pandemic that creates, disrupts local economies as a result of the lockdowns, leads to new drugs being injected, leads to more homelessness in the population. So we do have the capability of ending HIV epidemics among PWID. We do need to do continuous monitoring of these situations. It's not as if you do good prevention once and then you stop, but we need continuous monitoring and possible rapid response if an outbreak should start. Next slide, please. And still next slide. Okay. So in summary, we do know how to end HIV epidemics among people who inject drugs. In particular, we want to greatly reduce the percentage of people in the PWID population who are likely to transmit HIV. That is, the people who are seropositive, not on HIV, not on ART, and engaging in distributor sharing. And we want to reduce the percentage of people in the population who are likely to become infected. That is, they are HIV negative and sharing syringes with large groups of others, PWID. We know we can do this in both high and middle income settings, but to end with a quotation from Dave Purchase, the person who started syringe exchange in the United States, that prevention is never perfect and never finished. Next slide, please. Yes, thank you very much.
Okay, thank you so much, Professor Don. That was really quite some presentation. We really thank you from the bottom of our hearts. It was very heartening to see that we could perhaps be more optimistic about ending injecting related HIV transmission. Yeah, I just got some messages from some of our colleagues. If there are questions, I would just request you to keep it till the end, and we will try and take all the questions soon after Shona is done in the end. And in the meantime, you can keep posting it in the chat boxes. There is also options for doing some smiley and thumbs up in case you wish to encourage the presenters. Moving forward, I would now like to quickly invite Associate Professor Duong Thi Huang from the Phong Medical and Pharmacology University, Vietnam. Over to you for the presentation on ending HIV transmission amongst PWID in Vietnam. We'll basically be hearing findings of the DRIVE study.
Good morning, good afternoon, good morning, everyone. Thank you for ASEAN and SCDI to give me the opportunity to present the driver study finding a pattern and application. But please, okay, I find it. So as you know, previous my presentation, Dr. Des Jarlais already talked a little about the driver study, the reason why we do the driver study in Haiphong. The DRIVE is the drug use and infection in Vietnam, ending HIV epidemic among PWID in Haiphong, Vietnam. We have many partners to work together during 2014 until 2021. And you can see in slide, we work with SCDI, Hanoi Medical University in Hanoi, Haiphong University of Medicine and Pharmacy in Haiphong, Vietnam, New York University, Abbott, Center Pierre Cohn, Montpellier University in SAM, U1058, and Nîmes University. And also we have a support sponsor from NIDA, ANRS from France, and Global Fund. Here we have three investigators. You see here Dr. Des Jarlais, Khoti Haiwang, and I, and another one, Dr. Nicolas Nago from Montpellier University. He cannot attend this workshop. The reason why we do the DRIVE study, we already have Dr. Don introduced in previous presentation. The result combine prevention and care for the people who inject drug, get success in the high income study. So we want to do this, the combined intervention in the low income country, and do the monitoring how to control HIV epidemic in low income country as in Vietnam. The DRIVE project start in 2014 with main objective. First one is assess the HIV epidemic situation in PWID in Haiphong, Vietnam. And the second one is the design and evaluate the effectiveness of community-based combined intervention of ending HIV transmission among people who inject drug in Haiphong, Vietnam. So we use the definition of ending HIV transmission by WHO. So you already know from the Don presentation. So you look at the slide here, and please let me go very quickly. So the operation goal to reach the large number of PWID in order to assess HIV epidemic and establish HIV cascade of care and increase access to combined intervention. As you know, the DRIVE project, we do the annual ADS, 4 ADS during 4 years of with the previous pilot drive-in in 2014, and we started the driver with first the ADS in 2016, and up today we done all 4 ADS, and we follow the 2 group, HIV positive and HIV negative, select from each the ADS. The main crucial here we is very important role of. Pardon? So here we work with SIBO, and SIBO is crucial success for DRIVE project. They involved as a part of study research member. We during the driver during the OADS and follow-up visit, we using fingerprint to prevent multi participant in each ADS, and to identify individual participant throughout the project. And with the support, we during the each visit we do the questionnaire about the risk behaviors drug. We identify the drug activity by skin mark injection, drug urine test, HIV rabies test, HIV viral load, and HIV recency test to identify the HIV incident in HIV negative group. I will present later. But all the activity the CBO involved to during the visit flu observed. So you can see here in each visit we have 7 tables. The first one, all the table we have almost a table we have involving a CBO. The first one with the reception CBO to check the coupons, to check and identify the participant, and they follow the table number 2 with the admission and incentive, and the table 3 and 4 with the consent form and checks the eligible participant, and if the participant enrolled to study, we continue to do the blood test, interview, and the CBO take the contactation for the people meet criteria for follow-up cohort participant. So we see here on the CBO, they involve almost the table in flu observed for the X visit. So we start with the assessment of HIV epidemic situation in Haiphong. The question is what is the HIV epidemic situation in Haiphong? So from the first ADS survey conducted in 2014 with the 603 PWID recruited in during more than 3 weeks on the community side. So we found the HIV cascade of care. Here you know the people HIV positive, PWID HIV positive, and we found only 70% of people HIV positive know about their HIV status, and among the people HIV positive on ART, about 68%, and people on ART is the 70% with the viral suppression. So the main question here is how to know how PWID know their HIV status and how we can enroll them and do the last HIV test and accept them to care. So it is the study based on, we found from ADS, first as ADS, we called try-in, done 2014. We found that is the main to obstacle to control HIV in Haiphong is the low HIV testing, poor health seeking behaviors among PWIDs, and unsafe practice when they do they practice the injection. So driver started to repeat error for error from 2014 until 2019, and with the community support for people HIV negative, they access to harm reduction program and possess the knowledge for safe injection and peer education for the participant. The purpose from the thing HIV epidemic we found from first ADS with the HIV prevalent, VMR prevalent is the 15% and HIV incident about 2%. And our goal at the end of project is we reduce the VMR prevalence is 70%, 7%, and HIV incident less than 0.5% meet criteria of ending HIV epidemic by WHO. So I can show you the success ADS to reach the people, PWID people. So we start with the first ADS in 2014 and the last ADS 2015, and each ADS we enroll about 1,500 PWIDs, and each ADS we win enroll for the 2 cohorts people, the HIV negative cohort and the HIV positive cohort, to follow the people to estimate the HIV incident in HIV negative group and to know the rate of HIV positive PWID to access to HIV care and methadone program. And the question is how we know about the size of PWID population in the city and know about the cascade of care. So we use the recapture with the UNAIDS guideline, and we distribute the object lighter you see here with the marker driver project, and the CBO distribute the lighter 1 week before the ADS start in 2016, and in the 1 week later the people invited with the coupon, they come to visit site, and in the questionnaire we can find the recapture people already got the driver lighter 1 week before. And with the NS guideline we calculate we estimate about the 500 activity drug people in Haiphong. And also we know, as you know, that the situation harm reduction in Haiphong, we start ART from 2005 and methadone program from 2008. With the methadone program right now, we know that about the 4,000 people on methadone program. So in theory, the people on methadone program, they have a low risk to HIV transmission because they change from injection to oral methadone. So we do among the 5,000 drug activity, during the 4 ADS, we enroll about 400 people. So it reached the 80% all the active people. And then in each area, we follow, we do the cohort HIV positive, HIV negative. For the HIV positive, we follow the viral suppression, and we follow the people can access the methadone, ART, etc. And we estimate the effectiveness of ART program. And the HIV negative cohort, we follow up the people in each every 6 months. We do the HIV test, and drug urine test to know their status using drug, and we follow if they HIV seroconversion. And I show you the service package in each area, and also in every 6 month cohort visit, the people can access the ART methadone harm reduction, and the SIBO is a main do the main activity to help the participant to access ART methadone. And I show you the key finding in the each area. You see here, we already done the 4 areas in 2019, but we have not that analysis, and so up here, but you see here 4 areas, 1 from pilot and 3 from drive project, and the HIV prevalence is a little similar in each areas, and the sharing in it about 3% in each area. But here the percentage of people receive got methadone is pretty high increase. So you know here is the good result. The intervention with the SIBO help the participant to access the methadone and harm reduction program. And you can see here cascade of HIV care with the first one in 2014, the second one in 2016 and 2017. And at beginning, when we do the feasibility of ADS in Hải Phòng, we found that is the very the lack of access HIV testing. So the only 70% of people, HIV people, know about their HIV status, and we do the last ADS screening. We make increase the number of people HIV positive to know about their HIV status and access to ART care, and the percentage of people with the HIV suppression increased in 2016 and 2017, and the last one the cascade of care is the stable, more than 19%. So with the HIV negative PWID follow-up, we estimate HIV incident with the we rate up with 3 criteria to identify the HIV incident with the HIV test positive, CD4 count more than 315 cells per minute, and viral unsuppressed. And recently we do the positive recency test supported by CDC. So during 1,500 PWID per year of follow-up, only one HIV seroconversion. So HIV incidence is 0.7 per 1,000 person years. It meets criteria for the ending HIV epidemic. The community viral loss, HIV positive participants who have viral loss unsuppressed among all PWID participants. We do HIV test and viral test, and we find 3.1%. The reason from cohort study, we found that HIV transmission in PWID in Haiphong is a control. We meet the criteria for the WHO. So the question is, how can driver be used for HIV response and other health issues? We use the answer is where are we with the HIV epidemic among PWID in various locations. We can use the sample method by using ADS and recapture. We can do estimate the size, population, risk behavior, and cascade of care, and identify HIV incident in PWID. And as an HIV intervention model for PWID, we can adapt in each local epidemic. And the first one is an opportunity to address other health issues among PWID. We can more comprehensive approach. Here you can see the model of drive, and the CBO can involve at the main point, main activities they do at the research party member. CBO can run a large scale ADS, and with the aerial ADS, we can answer the question: is the HIV epidemic among PWID under control? And if the HIV epidemic meets the target 19-19-19 and incident HIV incident less than 0.5% per year, if yes, so it means the HIV epidemic, HIV transmission in PWID is controlled, so we can retention HIV PWID, HIV positive PWID in ART, and maintain efforts with the support of harm reduction, maintain methadone maintenance treatment, and other health issues we can combine and to access to care for the PWID, like TB, mental health, and monitor behavior and drug trend. If the HIV epidemic is not controlled, found from the model of dry repeat ADS, not control, we do the intensity effort to increase coverage of combination intervention, and consider repeat ADS as an intervention tool. And each element you can reach the large PWID to do the HIV test and access them to ART care. So to implement implication of AIDS reason with the cascade of care. You can see here the first scenario as we did and found in Haiphong 2014 with the number of people know about the HIV positive is very no people to do HIV test. So if the HIV local HIV epidemic in the scenario 1, we do the intensity HIV screening and support treatment access and adherence. And if the HIV epidemic in the second scenario, we do the intensive HIV test, HIV positive, we engagement in care and check HIV care performance. And the last one, if the HIV epidemic in the first scenario, it means we get the target 19-19-19 and HIV is controlled. We continue retention in HIV care. From the result of drive model, we implicate 3 scenarios to apply in each local HIV epidemic, and we do the edit in other health service province outside of Haiphong. And in the next presentation, Dr. Oanh will talk about the result of implementation driver model in other provinces. But I will summarize a little about the feasibility ADS in other provinces we did in Vinh in 2019. So among 6 weeks, we enrolled 494 PWID in Vinh, and the drug the user drug situation in Vinh is the coverage of methadone is about 25%. 28%, and the number of people using methamphetamine is the 25.8%. And the HIV positive among 419 eligible participants enrolled is the 34%, 7%, and HIV positive among genre PWID about 3%, and recent CTED positive, no any participant positive with recent CTED, and only 2 HIV positive on ART treatment with the HIV virus, about 1,000 copy per milliliter. From the ADS in Vinh, we found that it's feasible to conduct ADS in other provinces where the strong local CBO and technical assistance, and no HIV recent infection among PWID in Vinh, where the service for harm reduction and ART service is quite good. So the HIV transmission in PWID in Vinh is controlled, is similar we found in Haiphong. And it meet the third scenario you saw in previous slide. So Ving is the continued for the retention HIV care. From the driver model and the feasibility AIT in other province outside of Haiphong, we think that use the driver model is primarily as an assessment tool to know what is HIV epidemic situation among PWID in various cities of Vietnam, assess the performance of the HIV care program in PWID and guide intervention efforts. So based on 3 slides you see in previous slide, we can guide the situation intervention. And driver model is not just an ADS, it is a rely on severe ability, capability building, plus additional benefits such as engaging some ADS participants in care, methadone and AIT, why they was not in care before. So if HIV epidemic is under control, reduce intensity effort, maintain the care and harm reduction, so we can save a resource to get the efficiency. The second, if the HIV epidemic is not under control, we can repeating ADS can be used for case finding purpose and engagement in care, as it can quickly recruit loss of hidden PWID. So if we do the dry ADS model, we have a assessment toolkit. You can see here, we do the urine test, HIV test, HIV viral test, and HIV region testing. And we need the support from the health service, from CBO to run data connection, and we need the human resource for testing, counseling, from the CDC, provincial CDC in each province, and intensive for PWID to participate, recruit other PWID by voucher, by coupon, and return to test result. So we need the technical assistance from Haiphong driver team and technical assistance from the international drive team from New York University, Montpellier University, and current now when we speed enlarge the ADS in other province by SCDI, we have a support from Haiphong Drive team, and also international Drive team member. They help and analyze data, and you can see at the Dr. Oanh presentation later. So that's all my presentation. Thank you for attention.
Thank you, Professor Duong. I think very comprehensively done. But equally, I just want, I was taking note of some of the key points you made. I think one of the very important messages that was coming out is, and actually building on where Professor Don left, was combination intervention is the answer. Perhaps we need to understand that for a model like DRIVE and for RDS approaches to be successful, there is a clear and critical role for communities to be engaged. And I think you've demonstrated that. And moving forward, perhaps, I'm not too sure, but I think you did touch upon young people and women also. I think we could look deeper into the subgroups of PWIDs also, moving forward in the larger region and other countries also. So thank you so much. And there, I can already see there is a question for you. We'll park it and take it in the end. Thank you so much. I would now quickly move on to the next session. And on behalf of Dr. Tam, head of the Vietnam AIDS Control Program, invite Dr. Oanh actually to make the presentation. Dr. Oanh, over to you.
Yes. Good morning, good afternoon, everyone. And Dr. Tam unfortunately have an emergency, so she has to leave. So she asked me to just run through her slides. So I just familiarize myself with her slide and just like go quickly through the story of Vietnam. And the story of Vietnam is ending HIV transmission among PWID, but at the same time to sustain harm reduction coverage. It's really the scenario number 3 in the presentation that Professor Huong have just delivered. This is the situation of HIV epidemic in Vietnam. We get the highest number of infection in the around 2006-2007, with 30,000 new cases detected every year, and about 10,000 people died every year. And right now we have, like, in first 6 months of 2020, with a lot of effort to identify to 5 cases, we have 4,000. We detected 4,000 cases. So you can see that is the new infection have reduced significantly in the country. At the beginning of the epidemic, the vast majority of HIV infection in Vietnam was among PWID. I remember when I started to work on HIV, which was 20 years ago, about 90% of HIV detected case was PWID, and now it's moving to sexual transmission. Also because the infection among PWIDs have reduced significantly. So the harm reduction in Vietnam, you can see from Dr. Tam's presentation, there are 2 important pillars. It's a policy response and program implementation. We have a lot of policy, important legislation and policy document on HIV and harm reduction. I think we can, one important milestone is we have a HIV law in 2006, which allow harm reduction with legalized substitution treatment and needle and syringe distribution. And then in 2008, we start to pilot methadone, and just a few weeks ago, we start to pilot take-home methadone. So harm reduction in Vietnam has scaled up very quickly and significantly. We have a needle and syringe distribution at the highest was like almost 40 million needles distributed every year, and distributing needle become a norm in the HIV program. The police was advised or was instructed not to disturb needle distribution or people to go to buy clean needle. At the same time, the methadone program has been scaled up. We have methadone almost everywhere now in the country. We have more than 300 methadone clinics all over the country, and over 53,000 people currently on methadone. And the HIV prevalence among PWID in Vietnam has reduced from around 30% in early 2000 down to around 9% now in the country. You see an increase, a bit increase recently is because of a lot of intensive effort to fight the case, HIV positive cases. So here you can see the new data. In last year, or 2000, in the year 2000, the HIV program used a recency test to identify the recent infection, the new infection among the key population. And you can see the result here for the country. Among female sex workers, the incidence is 0.2 per 100 person year. So it's very low. It's lower than the level of 0.5 per 100 person year that Professor Des Jarlais has mentioned. We also have among the PWID in many provinces, data show that we have achieved the level of ending HIV transmission among PWID. We have achieved the level is 0.4%, 0.4 per 100 person year. So we can say that in Vietnam, it's not only in Hai Phong, but in many places in Vietnam, the HIV transmission among PWID have been controlled, or we can say it is ending. The only one that you see that is still high is among MSM, and that is our next challenge. So here are some data on the impact of methadone on the people who use drug, on methadone consumption as well as the I'm not going to repeat that. I think this is what the lesson learned by our government. It is important to have a government policy that are enabling. It's important to have a multi-sector collaboration between the Ministry of Health, Ministry of Public Security, Ministry of Labor and Social Affairs. We need to have a rapid scale up of harm reduction program and to facilitate the access to harm reduction services, that the service have to be convenient, accessible. It have to be easy, simple, fast, and the procedure have to be flexible so people can access it quickly. So service need to be confidential and had to be created. We open to the breakthrough and new initiative. And I love the last point of Dr. Tam is the greater and more meaningful participation of civil society in the response. So these are the 4 lessons learned from the VAAC, the Vietnam Administration of AIDS Control, for the harm reduction in the country. And that's the end of Dr. Tam's presentation. If you have a question, later on in the Q&A, I will try my best to answer on her behalf. If I can't answer, I will forward them to Dr. Tam. Thank you.
Yeah, we are noting all the questions, Juan, and we will bring it soon after Shona's presentation.
Okay.
So Juan, it's your presentation only, the next one. So yes. Please continue.
Okay. So now I can do my presentation. So as Professor Des Jarlais and Professor Huong already mentioned to you, I am also involved in the DRIVE study as a co-principal investigator, and SCDI have been participating in the study, in particularly to support the community-based organization to in the study for the last 6 years. So we are intimately involved in the study, and we can learn from it. So my presentation is from drive to cheers. So drive is the study, and cheers is a program that we use the evidence and lesson and tool of drive to implement the program. So first of all, I want to say that we are able to implement drive and now implement cheers because we have a community system in place. So starting in 2011, the Global Fund supports civil society in Vietnam to work on HIV. And one important component of the Global Fund support for Vietnam is the community system strengthening. So with the funding from the Global Fund and the political and technical support from the Global Fund, we are able to build a strong network and system of community, in particularly the community-based organization, the organization run by the member of the community, in particularly the key population, people who use drugs, sex worker, MSM, transgender, people living with HIV. So my organization, SCDI, implement in 5 provinces. And right now, in 5 provinces, we have 24 CBOs that implement the program. They are the ones who deliver services and support the community in their province. So among those 24 CBO, there are 12 CBOs of people who use drugs. So in the program, CBO do everything, basically. They do outreach, they do communication with the community, they do lay test or community testing, they refer people for treatment and for other medical services, and they provide treatment support, either methadone adherence support, ARV, or TB, or mental health, etc. So in drive study, which was started 6 years ago, CBO in Phong, it is one of our 5 provinces, have enrolled, have participated in drive study from the very beginning, and they have demonstrated their competency in implementing more sophisticated program. So they learn to manage the different software, computer software, using tablets for data entry and monitoring of the data. They are able to learn the knowledge, some of the technical knowledge, and a lot of skill. And another thing is we have a very strong collaboration between CBOs across key population. So in one province, it is a CBO of MSM, CBO of sex workers, CBO of ID work together and support each other. And in all provinces, we have a strong partnership with the provincial AIDS center or the CDC of the province. So, CHEERS stand for Community HIV Epidemiological Evaluation and Response. So it's not only evaluation, it's also response. It is community-based. It's based on the epidemiological understanding of the situation in the community. So CHEERS is implemented at provincial level by CBO. And we apply drive methodologies in order to do 4 things. One is to do size estimation, so for us to know what is the size of the population, to increase reach to new clients through RDS. We can do the epidemiological evaluation. We know where we are with the epidemic, as well as a program. And then we can deliver differentiated intervention based on the situation, the zero status, on the treatment situation, on the needs of the participant, of the client. So our overarching goal for CHEERS is to reduce incident and leading to control HIV infection or leading to ending HIV transmission among key population. So with the methodology of CHEERS, we have 4 specific objectives for CHEERS. And we started first with an RDS, a respondent-driven sampling survey run by CBO in a CBO office. The CBO is the one who managed all the data collection, recruitment, and data collection. Most of the data collection activity conducted by the CBO, from fingerprints to check the eligibility, to do the questionnaire interview, to provide counseling, etc. So far we have done quite a number of RDS. We use it for PWID, and we also now apply it for MSM, and it worked well. But among the MSM, it's another conversation. So we have, in our 5 provinces, all have completed the RDS. So Phong has been like far ahead. And then we have one in Quảng Ninh just completed 3 days ago. So we haven't got the data, all the data yet. But you can see the cascade of care on this for 3 provinces. You can see that in Nghệ An, they already get the over 90. In Ninh Bình province, the same thing happened. In Thái Bình, not quite, but almost there. And if you look at this cascade, you will see the yellow column. We put the yellow column particularly to remind ourselves that these people, they have a viral load between 20 to 1,000. So they have a viral load suppression, they achieve viral load suppression, but they haven't achieved the undetectable viral loads. So they are the one that we need to give attention to. So now we know that provinces have or almost have achieved at least 90. There's almost no new infection. In all 5 provinces, we didn't record any new infection. And but there are some people who have not achieved undetectable status, and because we do the RDS, we know who they are. We know that there are people who are vulnerable to low adherence, to overdose, to being arrested, to not access to health services because they don't have ID paper, they are still using drug, they are using methamphetamine, they have mental health disorder, they are not on methadone. So we know their personal situation when it comes to drug use and harm reduction and health service access, so that we can support them to improve their situation. We also learned that vast majority of PWID don't share needle. There are few people who continue to share, but as Don mentioned, when they are in the close group between sexual partner, between close friend, it doesn't seem to matter that much to the epidemic. And we also know that syringe and needle are readily available, affordable, and almost like every PWID in Vietnam, in all the provinces that we work, can access to affordable clean needle through commercial channel, through pharmacists. So when we do RDS, we reach a large number of PWID, but we keep contact with them and we follow up with them. We follow up with everyone who is HIV positive, and with everyone who is HIV positive, first priority was given to the people who are not on treatment. And then for the people who have viral load on treatment, but the viral loads over 1,000, and then to the people who have a viral load less than 1,000 copy but detectable. so it's over 20. And then we also pay attention to the people who have an undetectable viral load so that they can sustain their treatment adherence in order to maintain that level of viral load. So what we want to achieve is our CBO work with the client, work with the PWID who are HIV positive to ensure that they achieve undetectable viral load. That is the goal. And then for other people, for the people who are not on methadone, we discuss with them about methadone and we try to help them to assess methadone to overcome the challenge and the barrier. And for the methamphetamine user, which is increased quickly over the last couple of years, we start to do harm reduction for ATS user and do the ATS intervention. So CBOs also work on other intervention like help people to get ID paper, to get social health insurance, to have a TB screening, to assess hepatitis C screening and treatment, to mental health and assess the social welfare program, including assess support during COVID. And to everyone, we do a lot of communication and peer support. So here is what we have learned after 1 year of using DRIVE's methodology and using it in the CHEERS program. First of all, no longer elephant in the room. So we know where we are now. We know what is an epidemic. We know who need which kind of help, of support, so that we can target the intervention. The CBO capacity is strengthened. They are empowered. They are even more confident than before. And the CBO shared with us that they improve the teamwork among the CBO staff, because before each of them doing individual outreach, but now they work together in a team during the RDS but also during the follow-up care. So they increase the teamwork. They can reach the new client, the new people. Usually CBO who are the peer educator who come from the population, they can reach quite a large number of KP, but after a while it run out. It's hard to reach the new people. But with RDS, we can reach new people. And we can deliver targeted, personalized intervention. We are able to follow up epidemiologically and behaviorally. And now we have also applied the similar methodology to MSM, and it seems to work very well. But among the MSM, there's a lot more new infection. So I think that's the end of my presentation. I will stop here and over to you, Kuna.
Thank you, Oanh. Before we move to the last presentation, just on a lighter note, Oanh, you were talking about drive to cheers. You know, in some of the countries, it's what you call a criminal offense if you drive and then do cheers in the car. So no, but it's a very nice presentation, Oanh. I just wanted to highlight that. Again, what's getting reinforced across all the presentation is also a very strong CBO collaboration that you've talked about. And additionally, in terms of the approach, what seems very different is also a decentralized approach to doing things in Vietnam, because a lot of harm reduction programs still are doing a lot of things, especially advocacy at the national level. Service delivery is more concentrated on in the conventional pockets, not necessarily where new infections are happening. And third part is you kept alluding to working across community groups. I think that's another important area, because the conventional understanding of PWIDs is also adult male population. So in fact, I saw some questions around from Thailand. I think Ponte asked about women who use drugs and stuff when you were presenting. So thank you so much, Juan. Very rich presentations. And for the final presentation today, also for our project that has that ends today, I would like to invite Shona. Shona just completed a very good study on the impacts made by this project across each country. And Shona, I would like to invite you to please present that to all of us before we move to the next, before we move to question answer after that. So over to you, Shona.
Okay, thank you, Kunal. And I'm gonna set up my, just one moment. Pardon for just a moment when I get the slides up. Are you able to see the slides?
Yes.
Yes.
Okay.
Yes,
Okay,
yeah.
great. Okay, thank you, Kunal, for the introduction. And it's my pleasure to be able to join you on this, the last day of your program, and talk about the results of some of the research that I've been doing over the last couple months on the impacts of the work that you guys have done. And it's important to take a time out and look at the big picture of the achievements of programs like this. It doesn't always come out so clear in the quarterly reports and reports that go to donors. So I hope that this exercise does a lot to highlight the kind of things that this type of programming can achieve. So as I talk today, keep in mind that this is not, this presentation is not a comprehensive overview of everything that was achieved by the program. It's going to focus only on highlights. And within that, it's going to focus mostly on the work that was done in Vietnam, just to kind of illustrate the kind of things that were achieved by HRAsia. So first of all, among the more important and sustainable changes that the HRAsia program contributed to were helping to bring countries' normative guidance in line with international normative guidance to ensure that it's evidence-based and based on what we know works. And we've already heard a little bit about that today in Vietnam. We know that Vietnam has established a new guideline on harm reduction for ATS users. That was done with support from this program. We'll talk in a little bit more detail about what kind later. And then we know Vietnam was among several countries who've begun to make take-home access of OST available. Again, bringing their approach in line with international normative guidance. The program did a lot to focus on increasing funding available for harm reduction. We know that this is really at the heart of a lot of the problems that still need to be addressed with access, is coming up with the right funding and coming up with funding from sustainable sources. The program supported research by Harm Reduction International that was reported in its report summing it up, that made it really possible to see what had been achieved and what some of the gaps were. This research and its results were used at the international level to focus discussions around priorities, but it also made things clear within countries. One of the things that it revealed about Vietnam was that OST is funded completely with state funds. So in a way, it enabled the showcasing of the important achievements of countries like Vietnam. On Vietnam, also, of course, it highlighted that needle and syringe programming is still very dependent on foreign funding. And now I do want to talk a little bit about something that happened in a country that's not Vietnam, on funding. So in Nepal, one of the biggest achievements of this program was that there was a 33% increase in funding for harm reduction. And when I looked into the anatomy of that change, and this is a very important change, there were a lot of things that contributed to it. But one of the things that came out in the research is that the exposure of governmental officials from Nepal to governmental officials in Vietnam, where OST is scaled up, where harm reduction is going forward was something that really influenced their thinking in a positive way. They mentioned Vietnam specifically. Nepal, as we know, is run by the Nepalese Communist Party. So for them to be able to see that their peers in Vietnam were supportive of these activities was a very important influence. Also related to funding for harm reduction, one of the things that the program did that's really important was to point out a potential source of domestic funding for harm reduction. Again, this is research that wasn't done in Vietnam, but because the program was international, Vietnam, of course, was able to hear and begin to contemplate the idea that the research revealed. So in Indonesia and Thailand, financial analysis showed a comparison between the amount of money that's spent on drug control and the amount that's spent on harm reduction. So in Indonesia, we see that there's over $250 million spent on drug control, while only 400,000 is spent on harm reduction. In Thailand also, we see that there's more than 7,000 times more money spent on drug control than is spent on harm reduction. So it raises the idea that redirection of a small amount of money from drug control to harm reduction could be a potential source of the funding needed to end HIV among people who use drugs. The program did a lot to counter stigma. It acknowledged that stigma of people who use drugs is one of the things that lies at the heart of drug policies that are harmful, of unethical treatment of people who use drugs, of underfunding of services. And in a lot of countries, there were varied approaches taken to reducing stigma. In Vietnam, this happened as well. There was work with mass media, extensive work with parliamentarians, law enforcement. I'll talk in the next slides in a bit more detail about how they approached reducing stigma and how some of the other parts of the program contributed to that, and then what those resulted in. The program did a lot to strengthen the engagement of people who use drugs in policy dialogue. In Vietnam, it strengthened the ability of people who use drugs to articulate their experience and expose their knowledge to people who needed that knowledge for the decisions that they were making. There were platforms where the voices of people who use drugs were heard by very high-level decision makers. This happened during the SARC workshops and the ASEAN workshops, like the one we're participating in today, at international conferences. In Vietnam, it also happened in national platforms. The voices of people who use drugs were heard by the National Assembly, who's contemplating drug law reform. They were heard by high-level officials in law enforcement. Hearing the voices of people who use drugs, who are able to talk about their lived experience and their knowledge about what programming works and what doesn't, contributed to increasing the acknowledgement of drug dependence as a health issue in Vietnam by some very high-level people. It contributed to a different understanding, a different feeling about the respect for the value of lives of people who use drugs. And ultimately, it did lead to change in policy and practice. In particular, as I mentioned in one of the early slides, Vietnam has adopted a new guideline on working around the use of amphetamine-type stimulants. And that guideline has a chapter that's specifically targeting addressing the needs of women who use drugs, as well as youth and methadone patients. In the process of working on that guidelines, SCDI was involved, as were women who use drugs. So their knowledge directly contributed to the content of this new normative guidance. In Vietnam, some of the most important and impressive achievements of the program, or contributions of the program, were related to changes that took place in a drug policy as well as in law enforcement policy and practices. So now there is a new draft of the Vietnamese drug control law that is under discussion. And some of the language in that new draft has changed and changed significantly. Again, acknowledging drug dependence as a health issue and prioritizing voluntary community-based treatment over detention. This is a big change, and there are a lot of ways that the program contributed to it. Vietnam also has a new training module for law enforcement officers that has content that deepens the understanding of drugs and encourages respect for the rights of people who use drugs and understanding of what harm reduction is all about. Over 7,000 law enforcement officers in Vietnam were exposed to that training, and it's part of the official way that police officers are trained in Vietnam. Also, the program contributed to the piloting in Hanoi of a program where law enforcement would be engaged in helping people who use drugs get to community-based treatment and harm reduction services instead of arresting them. And these are big, important long-term changes. So how did the program contribute to those? There were a lot of ways. Just to mention a few, and we heard about them a little bit in the previous presentations, but we see that there's a very strong cooperation in Vietnam between civil society organizations and different governmental structures. This was something that existed before the HRAsia program, but the HRAsia program enabled its strengthening. Through the HRAsia program, SCDI was able to establish an MOU with the National Assembly Secretariat, which helped it engage in the discussions that went around changing the wording of the draft drug law. In addition to that, various representatives of various government bodies from Vietnam were able to participate in a lot of different international events that exposed them to global best practices. They went on field trips and saw how harm reduction and law enforcement cooperated in Vancouver. They participated in international conferences where they were able to be exposed to like-minded decision makers. And again, as I mentioned before, the program made it possible for them to hear the voices of people who use drugs and be inspired by what they had to teach. Among the things that the HRAsia program achieved is something that's not as relevant to Vietnam. It's a lot of countries really helped communities be resilient in the face of the COVID-19 epidemic. And in Vietnam, didn't really need support from HRAsia in doing that because Vietnam's response to COVID-19 has been so strategic and precise and effective. But I left this slide here to show that it did have that impact in other countries, but also to re-emphasize the idea, I think that's clear from our session overall, is that the world has a lot to learn from Vietnam. And so as I go into the concluding slides of this presentation, and we can think about how programs like the HRAsia program make it possible for one country to learn from another country. And so thinking about some of its added values, first of all, the program contributed money directly towards strategic policy dialogue. Often funding for advocacy work and for strategic advocacy work is left out of country programs. It's often an afterthought. And so what HRAsia did is give each of the countries funding that could be used specifically to carry out advocacy activities. That funding was used very strategically. Each country was given support to work together with partners in the country multi-sectorally to design a blueprint for change so that they could have a common understanding of what change they wanted to achieve and what would be necessary to make that change happen. It was one of the keys to the success of the program. Another thing that was unique about the HRAsia program in terms of its added value is that it engaged very high-level decision makers and ones that were sort of beyond the usual suspects. It wasn't just engaging the health sector. It also reached out to law enforcement, to parliamentarians, to religious leaders, to a whole gamut of people who have important roles in deciding how societies relate and react to problems that are happening. So this was something kind of unique that the program was able to do, to sort of look at how to do this advocacy work in a bit of a new way. The program provided international platforms for the exchange of knowledge, to build solidarity. I mentioned that interaction between Nepal and Vietnam, where people who were engaging maybe for the first time on policies where it seems to be a sensitive issue, when they could see that their colleagues in other countries have been effectively engaged in this kind of work. It empowered them, it gave them ideas, it made them feel that they're not alone in promoting certain policies. It led sometimes to sort of a healthy competition, these multiple occasions when countries were able to come together and share news, knowledge about their achievements. It enabled them to have some pride. Again, it's inspiring sort of healthy competition. Again, this was done through workshops like the one we're having today and multiple conferences that the program enabled people to participate in. It also enabled countries to interact and cooperate with global institutions like Harm Reduction International, like IDPC. These were beneficial for the countries because they were able to learn from their expertise, benefit from technical assistance, learning how to use evidence that was gathered. And it was also beneficial at the global level because it helped the global institutions have a better understanding of what some of the key lessons learned and key evidence coming from the countries were, and raise those issues to a global level for further discussion and impact on the narrative. Again, the program made possible bilateral exchange and cooperation that often isn't possible at all within country programming. And additionally, it enabled a unique degree of flexibility. The approach of the program in working with the blueprints for change and acknowledging that advocacy work is long-term and that as circumstances change, we can capitalize on new opportunities or have to react to new threats. You know, so for example, the progress that was made on take-home access to OST in 3 countries in response to the COVID epidemic, that was, you know, using that flexibility to act on a new opportunity. And one of the last added values, certainly not the least, is that it's important to remember when we work in harm reduction that it's a sensitive topic. Talking about drug policy is not always so easy. There are very strong opinions about it. And the Global Fund is a trusted source. The Global Fund is trusted to promote evidence-based policy, and countries appreciate that. So it reinforces the importance of support from the Global Fund for this kind of advocacy work. And just before I conclude the presentation, I want to reflect back on the theme of today's talk, which is about the future of harm reduction in the region and how to end injection-related HIV transmission. You know, we saw the example from Haiphong, which really can give us some hope that it really is possible. But we also know that there's a lot to be done to make that a reality in cities throughout the region. There's a tremendous amount of momentum that's been built through the HRAsia program, but there are also some important risks that need to be kept in mind as we go into the next year. We all know that the HRAsia program is coming to an end, and 2021 did not foresee a new Global Fund multi-country program that's focused specifically on harm reduction. So it's going to be more challenging going ahead to keep up the momentum that was created in this program. Another challenge that I see for the ASEAN region is that the region lacks a formal harm reduction network and now lacks a strong network of people who use drugs. In all of the other regions of the world, almost all of them, there's some kind of harm reduction network that exists as a repository of knowledge and sort of a continued driver of this multi-country solidarity and collaboration around building up harm reduction. So the lack of those two things are something to keep in mind as you go into the new year. It's not all about risks, though. There are definitely some opportunities out there as well. We know that there will be a multi-country program that's going to address the needs of key affected populations. There'll be an opportunity. It's important for there to be a strong component on harm reduction in that program, and hopefully one that enables the other key affected populations to benefit from the experience of HRAsia and the experience of doing policy change in harm reduction. You know, things like working with blueprints for change, encouraging bilateral cooperation, the international events, the engagement with global institutions. Those are all things that we know worked very well in HRAsia, which hopefully will continue in the other programming. We've learned that ASEAN can be an important program, a platform for multi-country dialogue and exchange. That's certainly something that could continue even if the HRAsia program is no longer ongoing. And before I conclude, I'd like to remind you to use the opportunities that you have available to give feedback to the Global Fund, to other donors, to remind them of the added value of this kind of program, and the contributions that it can make. You know, there's an advocacy battle there as well to make sure that this kind of programming can continue. It's always important to remember that policy change is something that takes a long time, and progress is measured and seen by looking and acknowledging incremental changes. It's not always possible to say so directly that, you know, what percent of one of the 390s or 95s was contributed to by this program. But it is possible to say that the program did make change. And so, again, just in conclusion, I want to thank you for the opportunity to be able to do this research. It's a pleasure to talk with people who are professional and passionate about what they've achieved. I've learned a tremendous amount from you, and I hope that you can all continue to work together in the future and that you find good, strong financial support to do so.
Thank you. Thank you so much, Shona. I noticed that for a change, there is no question. It means, you know, I think you've left people speechless. People have heard you, you know, point to point, kind of very convinced. We did. Ira and I were nodding at every line that was being said, and we didn't really have questions, but rather, you know, these are results that you have shared. And I think all our partners acknowledge it, all our partners understand it, and we feel really privileged that no one better than you could have helped us see what we have done. So, Shona, so thank you so much. I'm sure it's quite late for you there, but we just wanted to say that this was a very good way of ending the year, and the presentation makes us look optimistic independent of when the next multi-country grant comes. I think we'll all have to try. We'll all have to be heard. I think we need a lot of leaders like Juan to help us be heard. We'll do our bits in our own little corners. Juan, if you're okay with me taking 2-3 quick questions that are still pending. First of all, thanks to all our experts, including Shona, for the wonderful presentations. A lot of experts have already answered, and I saw some of the people satisfied with the questions the way it's been answered. So I'll just request Ira to take those questions that still remain to be answered, and then we'll move to Juan for the closing remarks. Ira, over to you.
Hello. So I'm going to start, good evening everyone and morning. So I'm going to start with, there's a question from Murdo for Professor Dawn. It's recognizing basically in South Asia, so just hold on a second, sorry. It's recognizing that in South Asia, there are large pockets of people who inject drugs who are hard to reach and in remote rural areas. So Professor, would you see a measurement of individual level needle syringe coverage as helpful? If not needed in routine programming, basically in routine programming and country monitoring, as well as the Sentinel survey efforts?
Okay, yes. Thank you for this question. Thank you for this question. It brings back memories of the first project I did in Vietnam.
Sir, we can't hear you.
Oh, I'm not on mute. Can you not hear me?
I can hear Dawn. I hear you well.
Okay.
Dawn, please.
Oh, okay, good. This brings back memories of the first project I did in Vietnam, which was on the border of Long Son province and China. And we were working with people who use drugs in rural villages as well as cities. And the roads were absolutely terrible. If you didn't have four-wheel drive, you couldn't get anywhere. But we were able to reduce HIV transmission through a number of means. First, we relied upon people who use drugs to supply sterile syringes to their peers. We didn't try to have everybody come into a central site. Rather, we gave large supplies of sterile syringes to people who use drugs and asked them to distribute to their peers. Second, we used pharmacies. All of these small villages tended to have one or more pharmacies. They were very small pharmacies. Typically the pharmacist and the pharmacist's family lived above the shop. They carried a lot of traditional medicines as well as Western medicines, but there were a tremendous number of pharmacies in these rural villages. And we worked with the pharmacists so that pharmacists would agree to sell sterile syringes to people who use drugs. We also used a coupon program where the person who used drugs would be given a coupon. They could go to a pharmacy, give the coupon to the pharmacist, receive sterile syringes, and then our program would reimburse the pharmacist for the cost of those syringes plus a certain additional percentage for the time of the pharmacist to do the exchange. So that we found that even though transportation was difficult, we could get out a lot of sterile needles to people who use drugs, relying on peer-to-peer distribution and relying on the pharmacists. It was somewhat difficult to evaluate that, other than we did HIV testing in cohorts, and we used HIV recency testing And we found we were reducing HIV transmission, but it was somewhat difficult to keep track of all the syringes going out, particularly when people use drugs would just go to the pharmacist and buy syringes. There wasn't any really easy way to count that, but we could count the number of coupons that the pharmacists returned to us to get reimbursed for syringes, and we could count the number of syringes given out to people who use drugs to share, to give those syringes then to other people who use drugs.
Thank you for answering that question. Sir, I have one more from Mr. Chamarun, that if the needle syringe practices cannot be changed within the community of people who inject drugs, what would be your advice for successful harm reduction program? It would, keeping in mind that it would be great to swap the injection, basically the injecting practice to get people on oral substitution in most of the countries, particularly in our region, if it is more easily available and accessible, but there is still low uptake. So what would be your advice for a successful harm reduction program for our region?
Okay, first,
and also linked with that is, what is it that can, what is it that we can do to stop the injecting and sharing practices amongst people who inject drugs?
Yeah, first, I want to emphasize it is definitely possible to change sharing practices. You can go from 70 to 80% of the people sharing syringes down to 2 or 3 to 4%. So it's not possible really to totally eliminate sharing, but you can drastically reduce sharing of syringes. You can also get many people to stop injecting through methadone or buprenorphine programs. The key idea there is to make the programs user-friendly, make them inexpensive, ideally free or inexpensive, allow many take-home dosages, do not throw people off the program if they continue to use drugs at a reduced level. You wouldn't throw somebody off their blood pressure medication if they didn't always take it perfectly. So that there's a lot of low threshold harm reduction practices that can be put into OST programs, and you see much greater uptake when you have the low threshold OST programs. It is still very, very difficult to get everybody to stop injecting, and we're working on new programs to try to reduce people from starting to inject drugs and seeing some effectiveness there. So there are a lot of things that can be done, although there's nothing that is a perfect solution.
Thank you, Professor Don, for your very insightful answers and explanations actually to the questions asked. I would now like, there's one question from Pontik from Thailand for Oanh. She is referring to the research, research done, the DRIVE research done. If there is any research information or research for women who use drugs, particularly in Vietnam.
Yeah, no, I think that, thank you for the question. And this is a very important question. We do have a strong representation of women who use drugs in the Vietnam network of people who use drugs. Actually, the women who use drugs, once they are engaged, they are very strong. And we have many leaders of the network of people who use drugs are women. But however, there are few research, particularly on women who use drugs. But instead, it's a research about drug user with the participants who are women. In our DRIVE study, we purposely at the beginning to select seats for the RDS are women who use drug, so that we have a small subset of women who use drug in our participant, and we have a group of women who then the peer educator or the outreach worker who then work with women who use drug. We have to admit that we haven't done the in-depth analysis of the women who use drug among our participants. It's relatively small, like 5%, 3%, 2%, depending on where we are. But we do know, we do have information about them, and it could be, your question make me thinking that we should do a more in-depth analysis, mostly the qualitative, I think, because the number is relatively small. But women who use drug, in our first study, our first try to run the data on those small women who use drug, who are a lot more vulnerable, less likely to be on ARV, less likely on methadone, more likely to have a mental health issue. So we didn't publish that because the number is relatively small, but we certainly can do more in-depth or qualitative analysis of the data, and more qualitative data to share. But thank you for the question. Yeah.
Thank you so much, Juan. In fact, in my first visit to Vietnam under this project, I remember having a bit of an intense discussion on whether we should have female-friendly services separate from males in Vietnam. And in fact, it was a learning that it's not always the case. I think each country has their own sort of systems, ecosystems, and ways of doing things. In many countries, you also need to sort of look at typology-specific approaches. In some countries, it's the other way around. So thank you so much, Juan. And I think we've come to the end of the program, but not before you do the ceremonial closing remarks, Juan. So over to you as the host, as the lead.
No, thank you so much. It is 7:30 p.m. here on the 31st of December. It's at the very end of the day of the 6 p.m. there in New Delhi. Dawn have to be with us from 5 a.m. in New York. So really appreciate everybody participate in this workshop, and we really want to end the year with a positive note. That's why we have this very year-end workshop, that we can, and we are so excited about that we can actually end HIV transmission among people who inject drugs. And we would like you to, we hope that you share this positive note with us moving forward into 2021. We have gone through a very difficult and challenging year, and we will see what waits for us in 2021. But for all of us who work on HIV, who work on drug, who work on harm reduction, we choose a difficult life. We choose to work on challenging issues. So challenge is nothing new to us. So onward to the 2021. I wish you a very, very good year with a lot of hope, a lot of effort, and lot of inspiration and success. And thank you so much, Global Fund, Nicole, Dr. Salil from UNAIDS. Thank you, Shona, for doing that great study. Thank you, Ira and Kunan, for putting this together with us. And thanks, Don, for waking up so early. He didn't sleep much last night, actually. He sent me the presentation just like 3 hours before the workshop. So I hope you will get some good nap today, Don. And thank you, everyone, for staying until this time. And wish you a very happy New Year, and see you in the new year.
Please put your